Good morning, Dr. Alejandro Badia here with another bi-weekly episode of the podcast, Fixing Healthcare from the Trenches. Today, I have the great pleasure of introducing a friend and colleague, Dr. Sanjay Sinha, who is an anesthesiologist and is really a trailblazer in something that we call regional anesthesia, meaning allowing surgeons like myself and many other colleagues to do surgery in outpatient centers without the risks of general anesthesia, without intubation, etc. He's the chief anesthesiologist at the Connecticut Joint Replacement Institute, the name telling you that we now commonly do joint replacements outside the hospital environment, where there is an infection, COVID, inefficiency, costs, all of those things. He has developed a number of regional anesthesia techniques, including one for knee surgery called iPACK block, which has been used all around the world. And his current area of interest, he'll tell you about it, is neuromodulation, including work being done at a very innovative company called Gate Science that we'll be talking about. So without further ado, thank you, Dr. Sinha, for joining us.
Dr. Badia, thank you for inviting me. It's a pleasure to be here.
Wonderful. So tell us the fact that these kind of major surgeries are now being done at outpatient centers is obviously a cost savings, but there's even some benefits as well, particularly because in the hospital, they may not have, the surgeons and patients may not have access to people as much like yourself. So tell us about some of these innovations.
Yeah, so as you all know, or especially in the medical community as well as patients, realize that there is a migration of surgeries happening from the inpatient or hospital setting to outpatient centers. And there are a lot of advantages to it. These are small footprint centers, very efficient. They have the best sort of techniques. The surgeons are very technically skilled. The anesthesiologists are sort of in tune with the latest technologies and methodologies for delivering anesthesia. For the patients, it's an easy in and out. They don't have to worry about parking, and the care that they get is comparable to what they would get in an inpatient setting. But there are certain challenges as well. And one of the challenges is that surgeries with high pain burdens or complex surgeries are now being performed in outpatient centers. And we can get these patients through the surgery with our novel sort of techniques and the surgical sort of skills, the technology that is used. But when these patients go home, they have this pain burden which exists for days and weeks after surgery. And so it is important that even though we can get the patients through their initial care, their surgery, and their immediate postoperative care in the outpatient surgery center, but when they go home, the pain burden exists, and that can last for days and weeks, and that has to be taken care of. And to be able to take care of that, there are multiple techniques that are being sort of studied and looked at. One of them that I'm interested in is neuromodulation, combining nerve blocks and neuromodulation to be able to control the entire episode of postoperative pain.
So when you say neuromodulation, I assume you're speaking also about the electrical component, actually.
That's correct.
So maybe perhaps you can go into that.
Right. So neuromodulation has existed for decades in the chronic pain clinic, where it has been used in chronic pain patients. So spinal cord stimulators, implantable electrodes around nerves, and they are very safe. They have been used, as I said, for decades. The use of these technologies, or use of delivering a tiny amount of current to a peripheral nerve in the acute pain setting, or the postoperative acute pain setting, is sort of novel. We know that it works in the chronic pain setting. What you're trying to assess is how well does it work in the acute pain, immediate post-surgical setting. And it does have certain advantages. The advantages are that you can deliver pain control for a long period of time. So just sort of rewinding back, typically in the past, we would do a nerve block, and maybe put in a catheter right next to the nerve and inject some Novocaine-like medication, and then use that catheter hooked up to a pump and infuse local anesthetic over a period of days, up to 3 or 4 days. Um, Once that nerve block wore off, the patients would have some kind of rebound pain and pain that would sort of persist for days or weeks, but it would take care of that pain in the first 48 to 72 hours. With neuromodulation, we can extend that time frame for up to 30 days. And that is the advantage of neuromodulation. The other advantages are that it doesn't cause any kind of motor weakness, so the patients can, start the physical therapy and do their rehab fairly quickly after when they return home. So that
With these, we all know there's been some problems with some of the indwelling catheters. I can tell you from experience, I had a shoulder surgery many years ago, one of my first of several. And I remember the catheter started leaking. And I remember even Christmas Day, I had to kind of pull it. And as you said, that's when the pain kicks in, right? So the idea of this, of course, would be to extend that to hopefully 30 days, which by that point, most people don't even have much post-surgical pain, correct?
Right. And Alejandro, the other way of thinking about it is, so in your case, when they had the catheter, there was a tubing that was hooked up to a pump, and that pump kept infusing a little bit of Novocaine. Over here, we're replacing that tubing and that pump with a stream of electrons.
All right. Oh, much cleaner. Yes, certainly in my center. I mean, I've been doing total shoulder replacement, reverse shoulders, et cetera, for at least a decade now, outpatient. And the advent of Exparel, right? This long-acting bupivacaine, lysosomal release for the patients. Public listening. This is a way for someone like Dr. Sinha to do a block in around the area of your collarbone, your clavicle, and that would potentiate that and last for 2 to 3 days. But now with neuromodulation through Relay is the name of the device, right? Relay, which made by that will be commercialized by Gates Science, will deliver this sort of relief, which is impressive. I mean, really impressive for 30 days. Because I can tell you, in my, you're an expert in knee. I had a tibial osteotomy, and I can tell you, I never had knee pain, which is incredible. For somebody cut my tibia, because by the time the Exparel wore off, which is made by Pacira, by the way, pharmaceuticals, as you know, by the time it wore off, I really didn't have pain. But many other surgeries or many patients may be more susceptible to pain. And now with the neuromodulation, that is a game changer.
Yes, indeed. And we are looking forward to our product has been approved by the FDA to start clinical trials, which will be starting this month, actually later part of this month. And if everything goes well, we hope to commercialize in Q1 of 2025.
25, yeah, a year. So get ready. I mean, this is the pain. I mean, one of our friends and colleagues who has a much more widely watched podcast named The Ortho Show, Scott Sigman, is known as an opioid sparing surgeon. And Scott has really been instrumental amongst my surgeon colleagues in bringing these ideas forward. And I think that the time has come because of the opioid epidemic. If people haven't watched some of the films now that are out there about what happened with Purdue Pharma, one of the books I recommend is Empire of Pain. I read that about 6 months ago. So this has far-reaching implications for our society, not just individual patients with pain relief, but we will be able to minimize people getting addicted to these painkillers.
So just to say, Scott Sigman, the original opioid sparing surgeon, is part of our advisory board. He has termed the analgesic gap that exists between acute pain and the pain that follows thereafter, after the first 48 hours or so. And neuromodulation, our device, sort of is going to take care of that analgesic gap that exists. So
it's very necessary, and it fits into what I've been trying to talk about, whether it be through my book, Healthcare from the Trenches, or this podcast, is the need to make healthcare more efficient. Because the technology is there, but the problem is it's incredibly costly, as we all know. And if we can migrate a lot of these surgeries from an expensive hospital environment And as we all know, we need hospitals. I mean, it's
Right.
but the reality has come that many of these procedures are quite expensive, and we need to think about our costs. And I'm
Right.
hoping that we could get some politicians listening, because in the last few debates, the Republican debates, healthcare is not even mentioned. So this is a big problem, and I think we need to educate them about this. So I'm going to ask you, Sanjay, which would you say are three initiatives, very bullet point format, three initiatives that you think could really bring down healthcare costs in this country?
So the first one that comes to mind is initiatives that are undertaken by physicians. They are in the trenches. They are taking care of patients. They see what is happening in their healthcare environment. They interact with colleagues and patients and the ancillary staff, and they have a finger on the pulse in terms of what the needs are, what the gaps are, and how to solve them. And so there should be initiatives that start from the physician, that should be taken seriously, and should be studied, expanded, and if they work, to be used in other hospital systems. So I think and this not only goes for physicians, but also nurses and physical therapy staff, who can come up with ideas that are novel, because they are working with the patients, and they get to see what benefits them, what doesn't benefit them. So
we need a seat at the table, correct?
Right. We need a seat on the table,
Yep.
and when we come up with an idea, it should be supported and nurtured, and if it is worthwhile, studied, and if it is worthwhile, it should be expanded, and other institutions should incorporate that in their practices.
Okay, so definitely engage the people in the trenches. So that's number one. Number two.
Right. Number two is, I think, the value-based care, where the stakeholders, the surgeons, the hospitals, the anesthesiologists, they all form a partnership, so to speak, and take care of an episode of care with a fixed price. So they are able to create efficiencies. These are not siloed kind of services that are being provided, but all the physicians, they work as a team to be able to get the best outcome in the most efficient way. And the value, of course, is the outcomes and the price. And in terms of outcomes, if the patient has great outcomes in terms of total knee replacement, they can in an elderly patient, they can go biking, they can go hiking, they can play with their grandchildren. And if that can be done at a lower price, with a team of clinicians, the physicians, the surgeons, the anesthesiologists, physical therapists, the hospital system, then I think that is a way of lowering or bending that cost curve, and an efficient way and a collaborative way of taking care of patients.
And ultimately, it's going to rely on technology, and I'll comment on that later. Now we have the tools to be able to do that, correct?
Right. And the last thing that I was going to say was basically technology. So there are going to be technologies that are coming out, that are already exist, are in the pipeline, like our relay device from Gate Science, but other technologies in terms of patient interaction and using machine learning, artificial intelligence, using large data to be able to create algorithms that benefit patient outcome.
So let's give it an example, right? With Relay, the idea is you will be able to control, and you'll be able to even report back your pain levels. I mean,
that's correct. That is correct.
Through an app, correct?
Yes. So our Relay device is controlled by an app, and because we have an app now, the app can then start interacting with the patients, because the app interacts with the device, but now it can start interacting with the patients and their physicians. So it can become a communication tool. It can collect patient-reported outcomes, and once you have significant data, you can then start using machine learning and create algorithms so that the efficiency of the system can be used much more efficiently without even patient requiring to change settings and so forth. And so those are the potential benefits of technology. And especially with this new artificial intelligence, I think, and large data sets, I think we will be able to predict patients who are going to do poorly or patients who will do well. If the patient is going to do poorly, how we can use intervention to improve their outcomes before they even have the surgeries.
Right.
Just to give an example, we can now use AI to be able to predict what kind of pain a patient is going to have after a total knee replacement, and if the patient is going to is one of those is a patient that is going to experience is predicted to have high pain experience, then we can start taking certain techniques that we can use. We can start education. We can set the talk to the patient, give them different kinds of therapy, and set expectations so that when they go into the surgery, they're much more prepared to handle the pain that happens postoperatively.
And even using the app to modify those settings, right, for those patients that we can predict.
That's correct. That's correct.
And these are the patients, right, that often cost a lot of money and the resources, right? They end up being readmitted to hospitals, for example, simply for pain. That's extremely expensive.
Yeah. One of the things, Alejandro, as you know, is after surgery, a small percentage of patients develop persistent pain after surgery.
Yep.
And if there's a way that we can control that persistent pain, then that would be a win, because imagine, there are about 60 million surgeries or so being performed. About 5 to 10% of the patients continue to use pain medications, become opioid dependent, and if we have a way of controlling that pain so that they never develop that persistent pain, then you can really have great outcomes for the patient as well as for the society, because of the opioid epidemic is still sort of ongoing. And I think these predictive tools or these AI algorithms are going to play an important role in many different patient conditions.
Absolutely, yeah. This is this is groundbreaking stuff. So, looking forward to that clinical study. So I'm going to give you my 3 initiatives. So the first one is the concept of having oversight, not authorization, by insurance carriers. Right? I think that our system is very bloated. I'm experiencing this today. I have a lady with a horrendous wrist fracture, and I'm thinking, why do I need to wait for authorization from a multi-billion-dollar company called United Healthcare, when in the end, once they've seen me, I'm kind of the best person to decide what needs to be done for that wrist fracture. And what happens is that ends up impeding the progress, and that costs money, right? So and yet, we're human, we make mistakes, and there's also overutilizers, et cetera. So we do need oversight in the system, but not hurdles.
Right.
Okay. Second one is tied into, say, that patient, right specialist at the right time. The system is still built to this sort of gatekeeper concept, and our primary care colleagues are way too busy to be, seeing that wrist fracture or shoulder or knee pain and saying, "Okay, I'm authorizing," or them. Right? We should be, those colleagues should be focused on keeping us healthy. So healthcare instead of sick care. Right? Yeah, and recognizing chronic disease problems early, managing them. Correct.
Right.
And the last one is tied into all of this, which is public and patient education. All right. If the public doesn't understand where our pain points are in healthcare, how can we possibly fix it? So one of the goals of my book of Healthcare from the Trenches wasn't so much to provide a lot of solutions. I wish I knew them, although I'm coming to understand, speaking to colleagues like yourself. But the problem is that the patients and the public do not understand what our challenges are, except when they have a problem. Then they start seeing, my gosh, why do I have this wrist fracture and I'm waiting for my insurance company to give some little number, right?
Yes.
So part of that is public and patient education, and that's the idea of this podcast every 2 weeks. So I will be able to keep the public updated with the progress from Gate Science and the great work you folks are doing. So I look forward to getting a report from you in the near future, Sanjay.
That's great. Thank you, Alejandro.
Thank you. So thanks, everyone. We'll see everyone in 2 weeks. And please, if you think this topic is of interest, please share it, spread it, critique it, what have you. But what we need is engagement. And right now, we're just not getting enough of that. The first point that Sanjay made was that the physicians and those of us in the trenches, nurses, technicians, etc., our voices need to be heard. So that's what we're trying to do here. Thank you very much.
Thank you. Thank you.